U.S. Preventative Services Task Force is recommending screening for adults, and the idea is to check for signs of anxiety disorders.
Anytime that anybody has a big change in their moods, it's an indicator that something's wrong.
Psychotherapist Gail Bibb explains some of the warning signs when you may need a mental health checkup.
When people are excessively worrying, extreme mood changes, highs or lows, having thoughts about suicide, or really difficulty connecting in social settings could be indicators that there is something wrong with your mental health. I think historically there's been a mistrust with getting services, getting adequate care that you need. Generally, I think a lot of African Americans have used the church as their provider for mental health. Particularly growing up for me, it was always whatever happened in the house stayed in the house.
Each one of us, we don't know what our breaking point is. We look like we're all okay.
My naivete is that I just inherently believe that if I look at you, and you look like me, it don't matter if there are slight differences or whatever. If you black like we black, if we black, we good. Even if you can't see yourself in me the way I see myself in you, I will grant you that humanity. And I will still work for you. I will still fight for you.
You know, we haven't even gotten to thriving yet.
No.
How do we thrive?
90% of black people have admitted to using religion as a coping mechanism rather than seeking mental health counseling or mental health professions.
My name is Tiffany Orozco. I'm a licensed clinical social worker. I got a couple different hats. So I am a therapist. I provide life coaching and psychotherapy, mainly individual therapy for clients that's struggling with, everyday, daily struggles, anxiety, depression, things like that. I have about 16 years of experience working in the social services field, and also 2 years working with crisis intervention. And so currently I'm a clinical director over a foster care agency.
My name is Lucretia Dillard. I'm a lead mental health consultant here in Contra Costa County, and for many years also a adjunct psychology professor, and I'm also a certified trauma trainer.
Hi, my name's Diamond McMillan. I'm a social worker. Currently, I work in a school setting, so I'm a school social worker. Previously, I worked with child welfare services for 14 years as a case manager, dealing with predominantly youth ages 16 to 21, so the transitional age youth.
So I work with the 0 to 5 population, the early intervention population, and the types of signs that I see with young children really stem from their family systems. It's usually another paraprofessional like a doctor or a family member that will refer them, or the county services will refer them to me to assess and evaluate their situation, their home life. Usually the presenting factors are the lifestyle of the family. There might be struggling with homelessness. They might have early trauma needs. The child might have severe developmental needs. The child might not be developing social-emotionally appropriately. So the referrals are a vast difference based on the child's development, their social-emotional needs, and the stability or instability of the family.
It could be a number of different signs, and what I've seen over my my career, my tenure of working in the behavioral health, is mainly anxiety and depression, and that's what I've seen lately with everyone kind of struggling with the the ramifications of the pandemic, and everyone just stuck at home. They're working remotely. They are kind of crammed into their house with their spouse, with their kids. But when I worked with behavioral health, a lot of people that I worked with had severe persistent mental disorders, schizophrenia, bipolar. I see some access to, and that's usually like personality disorders, narcissistic, borderline personality disorders, so a lot of different things like that, and a lot of trauma. And it takes people learning and understanding their mental health challenges. And like what I like to teach is a lot of empowerment around, like, you have a diagnosis, the diagnosis doesn't have you. And so when we teach that, it's about teaching them coping skills, because a lot of people, I don't know if you kind of have seen it, like, I'm bipolar, I'm this, I'm that, right? And it's like, what does that mean? And so I think just like teaching people and helping them understand what that is, because usually like it goes from like axis 1 and axis 2. Axis 1 is like the primary diagnosis. Axis 2 is personalities. That's something we can't change. That's something that's like embedded in you, like due to something that happened in early childhood, and it developed into a personality diagnosis. But then it just developed into these characteristics that kind of like show who you are and like the way that you behave. But they are trainable around like helping you understand and what that looks like for you. Absolutely. And mostly I worked in East Oakland, the heart of East Oakland. My clinic was located at Eastmont Mall, which is now Eastmont Town Center. And so I worked on a specialized team where we usually would get, like, they're called like level 1. And these are people that's one step from being in a hospital or one step from being in a state hospital because they've been deemed unrestorable or unable to kind of like be restored. And so what happens is they'll send them there, and because of like all the trauma and kind of poverty, and if you've been to Oakland, you've seen like how it looks now, right? And so due to those circumstances, people are unable to recover. And so what I've seen is like trying to meet the person and understanding their environment. And that's not what a lot of people are getting. They are just like assume like, oh, you have schizophrenia and we can't help you, but you can. As long as you're getting them the proper support and that they get assessed, then get on the right medication, they can be successful in life. But I think people just give up hope and not follows through and help them understand what they're dealing with. Especially young, Black, and I would say the majority of the clients were males, if they make it past their 18th birthday, because what happens is they transition. If they've had a mental health disorder, they've usually had it all their lives. It just when they get, sometimes past 18, 19 years old, that's like a late onset. And so what happens is they don't understand. And then family don't know, because we know what the Black community, what happens, the stigma around mental health. And so what happens is they're unable to kind of help their loved ones. And then that's how they end up on the streets. They end up in jail. They end up, in state hospitals. And they just end up kind of lost.
So oftentimes, if someone is meeting with some type of counselor or a social worker ongoing already, it's a little easier to notice the signs from someone that you have built rapport with. You start to notice their change in behaviors or their responses or their follow through. And other times you meet individuals in a crisis state, which means they could be an interaction where they were completely irate, or somebody might have been in a manic state. Or if you're working in a hospital setting, someone can come in and you're instantly in crisis mode and you're doing a crisis assessment, and so you know that they may actively be experiencing some type of mental illness that is more than likely untreated. I would say that when working with individuals that you meet with ongoing, it's easier to notice the changes in their behaviors or their moods. They may have an extreme mood swing and you instantly notice that they're not their quote unquote normal self. And then that will rise to the level of asking even more questions to see where that individual's headspace may be in that moment. So dealing with individuals who have either current suicidal ideation or past suicide attempts, for me it's a little hard to put an exact number on the demographics, because in my previous job, the students or the kids that I used to work with, they not oftentimes experience suicide ideation. There were probably, out of a caseload of 25, I may have had 2 that actually were actively having suicidal thoughts or past suicides attempts. And of all of the clients that I dealt with on my caseload, which again is a small portion, probably only 2% African Americans that were forthcoming with suicide thoughts. And I say forthcoming because not everyone is open to wanting to say that they've either attempted suicide or that they are having those feelings. And especially in the Black community, it's even smaller amount of people that come forward and actually admit to having those feelings, since it is frowned upon.
Some key functions that the Black community can take and do are to be in connection with a mental health counselor or therapist or social worker. To me, that's key, because we need to be able to understand what we don't know. One of the factors in treating mental health that's so difficult is that we don't ask for help. And so it's so important for us to keep people in the community that love and care about us and want to be alongside us in those walks where we start to address our transgenerational grief. That's number one. The other is to address our transgenerational family systems healing. It is alive and well in our families, and when it goes unaddressed, what we have is trauma transferred from generation to generation instead of trauma transformed. You know, there's lots of workshops for Black families just around reparenting, you know, just around family conflict, or even around grief and depression. You know, these are times when we teach our children how to cope and how to address their own needs. They become stronger learners and they become stronger adults.
I say the lack of resources. Especially, like, again, I grew up, born and raised in Oakland. It was a once vibrant, kind of healthy, cultural-driven community. And when they took away all the jobs, all the resources, it just went downhill. And then all the drugs came into the community. So I think drugs, lack of resources, just lack of opportunities. They start shutting down the businesses. And you know, when they shut down business, people lose their jobs. And so, just like I said, like, my clinic was at Eastmont Mall, right? And that was once a thriving, literally a mall. And so, and when I did some research too, I think that was also like a car plant long time ago. And so, and you know, that was like the blue collar jobs. So once all that, and there was a lot of other factories in Oakland as well, Mother's Cookies, like all these different things. So when all those jobs kind of shipped out or was outsourced, that's where everything kind of, and then the home values. People started moving out, and they lost the resources, and so they turned to drugs. And also too, a liquor store on every corner. So, yeah.
So have you found it that it's more difficult working with families than individuals?
Yes.
And how so?
The dynamics. So, you know, with families, unless it's a collaborative kind of approach, I found it hard. I've tried it. I found it hard because you got all these different personalities and you don't know who is the person that you're going to be, because when you working with a family, that's the client, not one specific person. The whole family is the client. As the person, the individual, you're working specifically with their challenges. And sometimes in the families, either there's an enmeshment, there is a scapegoat, there's an enabler. So it's a cycle, and it's hard to determine which person to treat and how to change that dynamic. I just find it a little bit challenging. Mental health is just as important as physical health. Just like we get up and we gotta feed and, nourish.
Especially as a Black person.
Oh yeah, especially as, Blacks. We've never been kind of taught that. We've never actually been, we've been taught to love and be kind to others, but we've never been kind of taught to love ourselves and what that looks like because of all the negative narratives that we've been showed, maybe told. And so we internalize that. And so, self-neglect, self-sabotage, self-doubt, imposter syndrome. I can keep going on and on and on, because it's even when, as Black women, Black men, we get to a certain level and then we start questioning ourselves. Am I supposed to be here? That's that imposter syndrome. I'm not supposed to be here, and so just really creating a community for yourself. And what that looks like is up for interpretation, because that's your community. So kind of like a pseudo family. So you have your, your natural born family, and then creating that other natural support system for you, and checking in with other people as well. Because sometimes we don't know. We think, the grass is greener on the other side, but sometimes it's not. Someone can be struggling. Sending out a text, just checking on you. Hey, how you doing? Have a nice, have a wonderful day. I hope your week is going good. Just simple things like that.
The other key component is health overall. When we talk about, adverse childhood experiences, we're not just talking about mental health illnesses that, are going to eventually dissipate and go away. Our mental health impacts our physical health, our physiological health. And so it's so important to go to the doctor and take care of ourselves. It's so important to find practitioners in our community that we can bond with and really service ourselves around, what our needs are as far as home life needs, and as well as our health needs, diet, exercise. It's so important to not separate the two, because we are, as people of color, we're dying at a higher rate than anyone else. And when we have high adversity needs, those things do bond with hypertension, cardiac and heart disease, wherever we're extremely at risk, trust and believe is impacting our physical health, and we don't live as long because of it. So I would say definitely, addressing your mental health needs and knowing that everyone has them and it's okay. And also addressing your medical and health needs ongoingly, having those conversations. And the other piece that I think is key is spiritual. Find a place where you feel clean and clear. Find a place where you can either use meditation, prayer, I don't care if it's mindful walks or mindfulness, but find a place or a community where you can commune and be who you are and be accepted, and have that community be able to be a part of your family life. It's so important that we have that for young children so that they know that there are other resources outside of their parents. That's another way that we can resource ourselves regarding mental health. Suicide, to me, is a very complex phenomenon in human experiences. I do think that suicide is something that we should think about in a much broader way. And what I mean by that is there's media now, And I think that if we look at the generational gaps of suicide ideology and see it now, there's something going on in the world with media, and it's impacting our psyche, and it's impacting our superego strength, and it's impacting our self-worth. And I do think that media is good because we can see where, if we take, for example, the situation of all the harms in the world, they can't hide it anymore because we can film it. But also the problem, though, with that much exposure to media, I think, is that we have lots of young people indulging in media, and they're using it as a lifeline. So I do think that suicide ideology is very complex. It's hard to answer in one question because there's this thing with media that's happening, that phenomena of toxic behaviors and toxic experiences being shared, and sometimes we're looking to the wrong people to learn how to cope through it. The other issue is that suicide ideology, in my experience in working when I work with teens, it was high in circles where teen addiction consistently had, circles of friends in which they would never separate from. And so the relapse rate was high because they were not changing the experiences and the social situations that they were in. And so to me, that's a direct connection as well to the rate of suicide with young people, because they're not helping one another when they are going through those experiences with each other where they don't have the right interventions that are holding them. And then we know that many families' addiction issues are transgenerational. So poverty is another issue. If you cannot get your needs met, you might result towards more at-risk and desperate measures that could lead to suicide. So it's a very complex, question. Is it direct or, is it an extension? I think that we should look at it in terms of it being something that is on the rise, and we need to be paying attention to all the antecedents. And for one person, it might be different than the other. I know some families, the level of depression has caused an increase in suicide in those families, and they're not in active addiction or, in poverty. So it has no discrimination. But I also see that there's this phenomena between young people where there's even movies about it now. And that's a good thing if you're a parent involved with your teen and you're watching those movies with your team and helping them to cope through some of the experiences that they're viewing. But some families seem to think that those type of movies are increasing the, desire to be in certain communities as teens, and that increases suicide ideology. But it's too complex to say that it's indirect or an extension. What I would say more of is that it's on the rise and that there are many antecedents. And more importantly, with young children, it's happening younger and younger. We see a rise of it, especially with young children, in relationship to being bullied and to being cyberbullied. Those things are extremely harmful to young children and really derails their development and their social emotional, growth.
I personally think that suicide can be a direct extension of mental health, but it can also be a standalone. Suicide can be circumstantial. It can be an after effect to anywhere from depression, from anxiety, from a car accident could trigger mental health or suicidal thoughts, but you can definitely be suicidal and not have any mental health issues at all. Someone can feel extreme worthlessness for a significant amount of time and want to possibly self-harm or take their own life and not have any mental health disorders or any illnesses that are related to that. Now, people who suffer from certain mental illnesses are more likely to commit suicide. For example, depression. One of the side effects of depression can be suicide, or extreme anxiety. Oftentimes, whether it's untreated mental health or treated, even some of the side effects for the psychotropic meds can fluctuate your moods. And when people have those extreme lows, you can really consider taking your own life, and it can go downhill really fast and hard to come up out of that black hole. In working with teenagers, it's a challenge in itself. In working with young African American teenagers, I see myself as having a little bit of a more open door and easier to build rapport because of my comparison to them. They may feel more comfortable when they look at someone who looks like them. There's also the age closeness. So I'm 37 years old, and so not that they can tell how old I am, but they seem more open to want to talk to me because I seem more relatable, which I am thankful for that, because then it helps me and gives me the ability to be able to support them. And I tell all of my clients, like, I can't help what you don't tell me. So if you want to come and you want to talk to me and sit there every day, every week, and give me a closed book, I can't help you. I can listen to whatever you want to say, but until you want to be real with yourself and real with me, I can't help support you. So I think that looking like you're like them is really helpful when it comes to trying to work out some type of treatment plan. Yeah, so I had a client in the past that was schizophrenic and also suffered from psychosis and memory loss. And one of the uphill battles with this particular African American girl was her mother. Her mother minimized every piece of disorder that she was diagnosed with. And so that in itself made it hard for her to want help. It made it hard for her to want to be open about what she was feeling, because she was always told that you're okay, you're fine, you just weren't having a good day, you just need some sleep. And so for her, it was kind of like being torn between what I need versus what my mom thinks that I need or don't need. And so with that, I had to provide psychoeducation with her mom. I had to get mom on board with the fact that your daughter really does need help, and she needs more help than just getting some rest or eating a good meal or going for a walk. And once mom was more accepting of the fact that, how she's behaving is out of her control, we were able to get her started on some psychotropic medications that were able to help stabilize her schizophrenia, because when she was carrying on day to day without any medicine, which I'm not really big on, but for some people it is needed. For certain disorders, it's very hard to function without it. And she would go into these phases where it was like talking to a black hole, and she wouldn't hear you. She would be sitting there, but would be looking into space and not able to articulate what she was feeling, how she may have even got to where she was at in that moment. And so a lot of talk therapy with her, motivational interviewing, and she was able to stabilize and able to attend school. She received her AA degree and was like self-teaching herself French, but it took for her to get back on medication because she felt that she was okay. And then when she felt she was okay and stopped, then it was a downhill battle from there. So really just making sure that there's supports When you have a positive support system around the specific individual, it helps with being able to have a successful treatment plan. I work at a charter school that is predominantly Latino and African American, so my caseload consists of more people of color than Caucasian. But when it comes down to mental health, some meet with me who don't have mental illness, but they still need the support, which is helpful because it's preventing anything to onset that could go to something that could lead down the line of a mental health issue that could affect their day-to-day life.
A lot of the parenting support that I give parents to help them, to support them in their parenting and their relationships with their children, especially young children, is I try to really support the parent in expressing what's it like in their world first. Having an understanding about what their life is like, what their home is like, their culture, their values. Then I get a really understanding of what their strongholds are and what their understanding is. I really try to support them in understanding their child at the age that their child is and where their child is going. And if their child has some delays or some areas that are still emerging, I really try to educate the parent with some psychoeducation around where their child's development is. I really try to encourage parents to think about their own mental health, their own social emotional development, how they were raised and how they were parented. It's so important to have those discussions, because when we do those deep reflections with parents, we really do shed the things that are not working for us. And the process of having parenting sessions, being able to talk about what's going well and what's not going well, is extremely helpful in giving them tools in their toolbox to really strategize how to model and teach their child. So often parents want their children to already know for some reason. But just as we teach them how to put their shoes on, we need to understand that a 4-year-old might very well know that the shoes go on their foot, but they're also at a very insecure age in their development. They might not know how to tie their shoes. So then that's going to might cause them a meltdown, or might cause them to feel insecure, and so you get a tearful child. So it's so important for us as parents not to react, but to learn how to respond.
Very important, because it's gotta work. You gotta get their buy-in first, and that's where when you start working with clients, building rapport, having them trust you, and you trusting them. And they're 90% of therapy is doing the work outside of the sessions. The other 10% is bringing it back and talking about if it worked or not. Because if it didn't work, okay, let's try something different. If it did work, okay, because I want to make sure once the therapy sessions are over, you're going to be able to continue to utilize this in your life.
What we know is that that's the amazing gift about the brain. What we don't understand is resiliency as much as we would like to, because we don't know why 2 children can be brought up in the same home, get all of their needs met, and one still struggles in life and the other does well. We don't know why. So there's this impact of resiliency, that innate ability to thrive and pass certain situations. Every brain is different. So really, trauma is in the eye of the beholder. We can have the same trauma, but it doesn't mean that we'll experience it the same and that we'll come out of it the same. What we do know about trauma, though, again, like I said before, is that when trauma is not transformed and we actively see it happening with young children, we can see their triggers, we can see the functions of their behaviors and their inability to cope and connect and attach and have good relationship with adults. We then can see that we need work right there with that child. We have a lot of work to do with that child, because we know that their ability to be able to do that is going to increase their social potential. What we don't know is why we can give children certain things at certain times, and it still benefits certain children and it doesn't benefit other children. So we have to get wiser in the world of psychology around cultural needs of families, really not textbooking families and really trying to understand who they are, what their needs are, and being with them in a more authentic way will help us be more mindful about the types of treatments and interventions that we support people with. When we filibuster people with our own agendas, that doesn't help. So we really need to think of trauma as in the eye of the beholder, and that it's such a complex process that it really takes time and real skill to evaluate and support people. It's too complex to really put your thumb on one thing, but to know that it is something that really needs a real, understanding of. And this is why trauma-informed practices are on the rise, because we need to be a system and a network of care. And that is something that I think is fairly new, in the field of psychology and social work, that we need to band together and be a system of care and not even be in silos as resources. We really need to be talking to one another so that we can do better to really intervene early when it comes to trauma.
That's a tough one. And I've seen different cases to where I'm like, you need some medication. I think it will help. But I do come from like a holistic approach because I've worked with a bunch of different doctors in the multidisciplinary team. I've worked with several psychiatrists, nurse practitioners. And so each doctor had their own approach. And let's say, for instance, someone has a diagnosis of bipolar. And with bipolar, it's a mood disorder mixed with some other challenges, right? And so you got someone that could be depressed for 2 weeks, and then you got, after they come off the depression, then they're manic for 2 weeks, and they're impulsive. And the behaviors that they're engaging in is harmful to themselves. Like they can run out in traffic. They spend all their money. They spend their life savings. They go on these trips. They put themselves in harm's way. They're sleeping with strangers, like different things like that. That's where someone needs to have some medication to help them manage their diagnosis. Schizophrenia. You got people, they're out of touch with reality. And so they're experiencing these negative, we call them negative symptoms of their diagnosis, hallucinations, auditory or visual. And so they need medication to help them regulate because they're out of touch with reality and they can harm someone or someone can harm them because they're not in their right mind, sort of say, right? So the medication will help kind of either calm the voices, help them kind of stabilize and get back to their baseline of being able to function, though they still have this diagnosis of schizophrenia. Depression and anxiety, I say, you can learn some mindfulness, breathing exercises, things like that, staying away from certain substances that can help kind of manage your anxiety or depression. I don't think politics really play a role because, what I've taught, just get my license. It's an ethical practice, and we have a kind of a code of ethics. And so what that means is like religion, politics, and things like that are kind of like to steer away throughout the therapeutic process to make sure that I'm remaining objective. And so let's say someone come in and they have these political beliefs. I try to redirect them and change the subject. I don't get into like a political, argument or talk about things like that. And I think when I was working in the clinic, that was different because working for agencies that's on a macro level, like Medi-Cal, different insurance panels, things like that, where they're like, okay, hey, you have to be on this in order to get this. And so pushing that, I still think that those are some things that needs to change and be revamped, because they are overly medicated people, and sometimes people are misdiagnosed. You know, some of the characteristics of schizophrenia mimic trauma, PTSD, because somebody didn't seen someone they love get killed. But then they're having nightmares and things like that. But again, that's where most African Americans and minorities are being misdiagnosed, because of like the things that they're experiencing. They're unable to articulate what they've experienced. And so these doctors kind of stick these labels on them.
When we're dealing with the system of education, and depending on what region you're in and how cultivated they are around cultural needs of children, you know, their bedside manner of how they support children and families, you're going to always be up against someone else's ideology about what's the best support for that child. And often these systems already have, you know, lots of hoops for families to jump through. And often those hoops don't feel good, you know, and so it is not what I call patient friendly or, you know, supportive. So politics and policies are things that we're often advocating for to be redressed, especially with young children, because often we're working with old frames. We're working with old customs and old ideas, and we're not being innovative and more, you know, understanding of the whole picture with the family. And so we will do these things to them in spite of, and it's not a mindful practice, you know. And one of them that I would say is health insurance. You know, in order to get services, you have to get a label. Well, if your health insurance doesn't cover certain things, that makes it political. And why is it that we have that sort of lawlessness in the country that we live in that's extremely wealthy? You know, children, and this is why we redress some of those by having so many services in which you don't need to be diagnosed to get the treatment. You know, so early intervention support has expanded in that way to try to help with those pitfalls. But often the very, you know, children we're supposed to be serving and helping to resource better are Black children. But often the policies around Black children are the very systems and different, you know, situations that end up pushing them out. And this is why we have to have Black voices in these circles, because we can't have spaces where we're dealing with Black families and we don't have Black paraprofessionals and Black educators. It is so important. We're often in these systems that are not for us and about us, so it becomes political the day we meet whoever we're meeting or the door we walk through. So this is why I was saying an ecological approach is going to be helpful, especially when you have people that look like you and me servicing children that look like you and me.
So having the right social worker, therapist, case manager, it is very important, but different institutions have the space or the option to change who you're working with or not. So for example, in child welfare, you don't have a lot of say-so over who your social worker is, right? So you're hoping to connect with this person and build a rapport and be able to work alongside of them. And then oftentimes, if you don't connect, then it could be a very bad, you know, time span with them. Now, you can complain enough to where you can get someone who you feel more connected with, but with a therapist, it's easier for you to pick and choose your therapist. If you're paying for those sessions, you can stop anytime. If you're working through an insurance company, you can say, you know, I'm not connecting with this person and I feel like I'm not being served or helped in the way that I need. And oftentimes it takes a while. I do suggest for people to go to several sessions with someone before they try changing, because anything new is always going to come with some kinks. And, you know, you got to kind of push through for a little bit, because if we say, oh, I don't like this person off of one session every time, you might go through 4 or 5 different people, where it's better if you like work with them for at least 6 sessions to see like, okay, this is doing something for me, and I might not have saw that in session 1 or 2, but now I'm seeing that this individual is helping me more than I anticipated. When you're in a school setting, it's a little different because of numbers. Staff is limited, so there may be one social worker that works with several different grade levels, and that's the way the cookie crumbles, and you have to just hope that you guys can make some type of positive experience with the person that you're I don't like to use this word, but stuck with. And so but when you're paying out of pocket, it's definitely easier to pick and choose who you want to work with. And if someone is, I definitely agree with, working with who you feel like you're connected to.
So what happens? How does that all work? I know that's a lot, but...
So going back to my experience in child welfare, I will say that every county should be the same, but it's not. Most of us we follow the same guidelines, but every county kind of does things a little different. So you may have some counties that are more conservative, whereas if a child is removed, we more than likely want them to be with family, right? So in an emergency situation, when a child is removed, they go through a list of emergency contacts. But with that being said, you have to look and see criminal background checks, previous child welfare history. And so oftentimes in the Black community, that is what is the downfall to a child going to a family member. If they have the wrong type of criminal history, I should say, because not everything will out someone from being able to take a child. But that already in itself, it puts our African American kids into the system faster. And then they're more than likely going to be the ones placed in the emergency foster care. And oftentimes the system, they look at it as if it's built against us, which means there's less resources. There's a lot of things that once a child is removed that you have to do to get your child back. But if you're already struggling as a parent, it makes it that much harder to attend court, attend your child visits, attend parenting classes, or if drugs are involved, attending the rehab and things of that sort, all add to an African American child staying in the system longer. It raises the level of failure because it is more challenging for African Americans to maneuver through the system. A lot of families that aren't African American oftentimes are able to pay for attorneys, private attorneys, and not get appointed the public defenders. And so there are good public defenders out there, but if you want to make sure that you're getting what you need when it comes to a child welfare case, it does pay to have money to be able to have an attorney that is going to push for you when in the court system. So then once an African American child is in the child welfare system, oftentimes you get bounced around. Why? You don't fit in, you don't like the house, it may be a different structure for you, you might not fit in at the school, and then there goes the next foster home. And then something might happen there, and then there goes the next one. And sometimes you're bouncing around until you get to that one family that is willing to take the chance on working through all of your tough times and waiting to see if your parent is going to get their things in order to get you back. But that also leads to mental illness, mental challenges, behavioral challenges, reactive attachment disorders from not having that sense of self, the connection to your family, and things of that sort. So it's very unfortunate that you see Caucasian children come into the system and come out less than 6 months, and then you have a lot of African American children that are in for 18 months to 24 months, and then they don't come home.
My main role is for everyone to kind of like to be empowered. I've always said I'll give back to my community as best I can, encouraging them to seek the support that they need and letting go of the stigma of the mental health. And if you need help, it's okay to be vulnerable. because suffering in silence is not conducive to anything. So that's my main goal for the Black community, that I recognize that everyone struggles, and it's okay. And it's okay to ask for help.
I originally wanted to be a lawyer. When I got out of college, I wanted to do law. But then I took a position at Child Welfare back in 2007, and I wanted to just help. I wanted to work with families that didn't have the support needed and be that bridge to a resource or connect them to, people that may be able to help them better their family. And I've always been someone in the helping profession, whether it was church or community groups, volunteering and things of that sort. And so I always feel like what you have, you need to be able to share with someone, even if it's just knowledge. It's not even always money. And so I'm really big on mentorship as well. But for me, my hope for mental health, and especially in the Black community, is just to provide space for people to feel that it's okay to be suffering and need support of someone else, that you can get the help needed for you to be able to function in the day-to-day and not feel condemned and things of that sort. And so for me right now, I'm currently working on my clinical license where I will be able to practice therapy full time, and I feel that it's needed because there need to be more Black therapists, and not just for African Americans, but for other minority groups, because again, being relatable, it makes you want to receive the support that much more. And I don't want someone to be with me just because I'm African American, but I want them to feel safe in that space to say, she looks like me, she looks like my cousin, she looks like my mom, and I want to talk to her so that I can get the help that I need.
In the 28 years of many different positions and working in mental health, I worked in foster care, I worked as a social worker, I worked, in clinical spaces and play therapy and different modalities. And the reason why I feel that my best purpose and worth is in early intervention support is because it's natural for me to be with young children and families. It's where I feel most confident in the work that I do. And I've had a lot of support to groom me to be in the position that I'm in. And I've learned a lot through the years. And I'm inspired by early intervention because I see changes happening with young children every day when they get their needs met in early intervention. And it inspires me to keep pushing and being a part of this, great community of early intervention specialists that keep working at understanding how to address these issues younger. And I see changes in the community with young children where they are able to get better. And so this is the community that I choose to work in because it's so impactful and it's so meaningful to me in so many ways. Just even being a mother, it was something I was drawn to. And for Black families, I enjoy working with my community. I enjoy being, a steward to support them. And I enjoy being a vanguard for this community because we need it, and I've been expanding my own, education and my own, practices to do better and better for our community because we deserve it. We are often othered and discriminated and pushed out. And frankly, as a Native American Black woman, I'm tired of it. And I want to leave a legacy behind to my children and my family and to the greater community where they can pick that up and do something with it. I think that we need to really think about who we are in these spaces. And for me, because I know my why is more impactful. What I do and why I do it is very closely connected to my every, situation, experience, position. When I am more intuitive and more in tune with families, I work better. And I needed to be trauma trained to be a better person. I needed to understand that things are happening to people and I can't just textbook my way through mental health support. And that is not at all the way to help a human being.